So the primary treatment options for patients with advanced CSCC include standard chemotherapy, platinum agents, taxanes, etc., or EGFR targeted therapy. So these are the EGFR inhibitor agents, and immunotherapy. Those are the broad systemic options for patients that are no longer good candidates for surgery and or radiation. Of the three categories, immunotherapy is appearing to be a more tolerable day by day. It's not without its own risks, of course, but in terms of day-by-day tolerability, it seems to be the best of those three categories. So why immunotherapy for cutaneous squamous cell carcinoma? Well, there are several reasons why this is a good disease to target with this approach. We know that the higher the tumor mutational burden, the believed better response to immunotherapy. And it's important to know that cutaneous squamous cell carcinoma has the highest tumor mutational burden of any cancer in the cancer genome atlas. The higher mutational burden is associated with believed to be higher neoantigen formation, and that kind of makes sense. So you think there's more new antigen formation with higher mutational burden. Therefore, the immune system might be able to recognize and attack this disease. We know that patients who are immunosuppressed, such as solid organ transplant patients, have a higher incidence of non-melanoma skin cancers and a disproportionately high increase in cutaneous squamous cell carcinoma. So between the higher tumor mutational burden and the known immunosuppression factor, this appears to be a good target for this type of therapy. As far as the mechanism of using an anti-PD-1 agent, if you look at a cell-cell interaction in a simplified way, you look at it as, let's take the antigen-presenting cell away and just look at the tumor cell interacting with a T cell. You can think of there being a major on switch to turn the immune system on, and that would be an antigen presented within an MHC complex by the tumor cell binding to T cell receptor on the T cell, and that turns on T cell mediated tumor destruction. So that's the major on switch. But there's a major off switch as well, which the cancer leverages for survival. And this would be the expression of the PD-L1 ligand, which binds to the PD-1 receptor on the T cell. This is the major off switch telling the immune system to turn off, which turns off T cell mediated tumor destruction. So the strategy here in the PD-1, PD-L1 axis therapy is to block that interaction. That can be blocking the interaction at the site of the PD-L1 ligand expression with an antibody such as atezolizumab, or it can be blocking the PD-1 receptor side, and the examples would be pembrolizumab, nivolumab, and cemiplimab. When you interfere with the major off switch, so you're turning off the off switch, in effect, you turn on the T cell mediated tumor destruction. So that's mechanistically how anti-PD-1 works. When you look at the Cancer Genome Atlas, and there's a nice graph of different tumor mutational burdens of different cancers from the Cancer Genome Atlas, you see that cutaneous squamous cell carcinoma is the highest in the Cancer Genome Atlas. Interestingly, the basal cell has even a higher tumor mutational burden, but it's not part of the Cancer Genome Atlas. So there have been studies also looking, new trials looking at PD-1s and case reports of efficacy looking at PD-1s for basal cell carcinoma.